Okay, well, welcome to the very last lecture of Biology 105 for the summer. Congratulations. About half of you, or most of you perhaps, have already taken the lab exam. Who took the lab exam already? So about half of you, and the rest of you are taking it this evening at 7, and a large number of other students already took it this afternoon as well. And that exam will be starting at 7 o'clock. We'll be out of there by 8:45 or so. And after this lecture, please just head upstairs and start reviewing some models. The first person who leaves here, if you want to take my key, can go upstairs and open up or I'll go up and open up that resource room so you can grab the models and study if I'm a little slower getting up there. So the lab exam is today. You should have your PALS quiz done when you go into the exam. That will only leave you after tonight's 100-point lab exam with the 80-point final exam. It's a non-cumulative exam. It covers just the respiratory structures, the urinary system, and the reproductive systems that we'll discuss today. There'll also be the quiz number 6 that you'll have outstanding that's due sometime tomorrow. So you'll have the 80-point exam and the 10-point quiz. After tonight, I'll have your lab exams posted and your PALS quiz posted. So all that will leave you is about 90 points left. And so you'll have the vast majority of your grade. And you can figure out what grade you need to make on that final exam to get the grade that you're shooting for. On that final, remember, exam 6 has vocab 91 to the end. And that includes a few pharmacological abbreviations that I'll go over with you now. And as I mentioned to you on last Wednesday, it's the same idea. You still have to know the term and what it means. But I'll be giving you a prescription pad and asking you to interpret the abbreviations that are used that the pharmacist will interpret and then write on the label for your benefit. So let's take a look at these. When you start off, well, first of all, any questions logistically, lab exam, lecture exam, final grades, anything like that? Nancy?
When I did the panel today, I
Yes.
noticed that histology I was really lacking in that area. So I got frustrated because even though it was open book, I was having a hard time finding
Okay.
what I was looking for to help me know, what to look for on the. So if you could point us in the right direction, like where can we find it, or here in our.
Well, there were the 7, okay, so there were, in the end of the lab supplement, there was a review page that told you what slides we had looked at. And it said we'd looked at the neuron, we had looked at the cross-section of the spinal cord, we looked at the cross-section of the small intestine, we looked at the some trachea, some lung, some kidney, sperm, ovary, seminiferous tubules, and cross-section of the penis. Right, and those were all listed in that one page about the slides that we've looked at this semester.
Okay, I think I was looking at the wrong page, because when you referred to that, I saw a page that had all of 3 columns of.
No, that was 3 columns for the fetal pig. There's a 1 page toward the end of your supplement, Nancy, right after your PowerPoints for Lab 11, and it should say Review Week 2 or something like that. And it says Lab 6 we did this, Lab 7 we did this, Lab 8 we did this. I went through that with you in lab last week and kind of reminded you what we did in each lab and highlighted those slides with you as we were going through it. So those are the slides you want to be thinking about and anticipating seeing on the exam. There's like 7, maybe 10, about 10 slides that you should anticipate seeing and knowing a little bit about them. And those who just took the exam, what do you think? The one thing I heard mumbling in the hallway was histology, so your mumbling is consistent with the mumbling I heard in the hallway. I wish I had spent more time on histology. So there's probably 3 or 4 questions in there that students are a little bit frustrated with. Okay. I know the mumbles. Okay. Okay, so let's take a look. Vocab for the last little portion. There was that last little bit, the V's, the W's, the X, Y, Z's terms, and then this. If you look at this, this is just a generic prescription pad taken off the internet. What do you find on this? What sort of information do you find? You'll see the RX. Now, RX stands for Latin word meaning recipe, which basically is telling you to take this. And it'll include the drug's name, the strength of the drug, the dose, 25 milligrams or something like that, and it will include how many the doctor is prescribing. If you're taking it once a month and it's a long-term med, you get 30 of them. If it's twice a day, you would get 60 of them at that time. There will be also, especially if it's an older doctor, you'll see SIG. and it means right on the label. Okay, so this is, again, this is Latin abbreviations and vocabulary that are telling, the doctor is telling the pharmacist, write this on the label in English, right, for the patient. And in these abbreviations, there will be the amount of the dose, how you should take it. Is it by mouth? Is it by IV if you're in the hospital? Is it by injection if you were in the doctor's office? And how often is this medication to be given? So the abbreviations would include the following: ATC, around the clock. That simply means that if something's being given 3 times a day, ATC, it must be given at very regular doses every 8 hours. And some antibiotics you can't just take whenever you feel like it. So if I were to say to you, you're taking a drug 3 times a day, when are you likely going to take it? Breakfast, lunch, and dinner. Other people, breakfast, supper, and bedtime. Others, it would be breakfast. You see what it can change, right? Your 3 times a day might be different, and you may not take it at every 8 hours. If it were every 8 hours, then in the hospital, they'd be on top of it, and you'd be taking it every 8 hours, even if it wasn't convenient or with a meal. BID, twice a day. C, or C with a line over it. That's what didn't show up on my PowerPoint, but C or C with a line over is cum, meaning with. Capsule, pretty straightforward. CR is tomorrow. DIM, half, and DX, you'll see a lot of terms with X in it. DX is diagnosis. GTT or GTTS, drop or drops. HX, referring to the history of something. IM, into the muscle. IV, into a vein. NPO, nothing by mouth. So if you are about to go into surgery, they might say nothing by mouth for 24 or 12 hours or something like that. OD, every day. We all know OZ is an ounce, but an ounce is also equivalent to 30 cc's, or 30 milliliters, which is equivalent to 2 tablespoons, big T. PC would be after meals. You'll also see it with food. So PC after meals, assuming you got food in your stomach, so you might see PC after meals, you can add there with food. PO, by mouth, from the Latin it means per oral, so by mouth. PRN, so, some of you may work PRN only as needed, so you're called in to a shift PRN as needed. So that might be true of a medication. If it's a pain medication, take it PRN. Don't take more than you need, only take it as needed. Q, each or every. QD, every day. QH, every hour. QID, think quad here, 4 times a day. QOD, every other day. RO, to rule out. If a doctor is about to send you to have an MRI, it's a rather expensive procedure, then they may have to justify to the insurance company why they're having it done, to rule out something else. Or if they're giving you, having you sent down for lab tests, and they're having you check your blood glucose, well, they're going to rule out diabetes. So they're going to put in there sometimes a justification of why they're having the test done to rule out some other disorder. S, or again, with a line over the top, that would be sine or without. Stat, do it immediately. T, 3 times. TSP, teaspoon. And 5 cc's or 5 mLs. Now, you won't see these as much anymore. T and big T, little t is kind of getting out of fashion because of all the errors that can happen. Big T, little t, I mean, people, if you're giving someone tablespoons and they're supposed to be teaspoons, you're giving them 3 times the dosage. And that can be a real problem with some medications. Again, that big T, tablespoon. TID, 3 times a day. TX, treatment. And Z, also for teaspoon, not to be confused with the little t. So those are the little abbreviations, and what I'll have you do basically is interpret. So I will give you a script. It'll have some abbreviations printed on there, and I'll say, hey, what does the BID mean? What does the PO mean? What does the SIG mean? What does the RX mean? So just make sure you know what would be included on a prescription pad, and that will be part of your vocab section on exam number 6, your final exam. Any concerns about the last little bit of vocab? There aren't that many actual terms, are there? Zyg, zero. There were few, but not that many terms. You guys are doing pretty well with your vocab, so I'm not too concerned. Now, the reproductive systems in Martini are one chapter, right? Is it one chapter combined? Everybody looked ahead? I'm thinking to myself, Martini has both male and female in one chapter, whereas my other book had it in two. So this is only a single chapter presentation. And I'm just going to give you some highlights of the reproductive system. You've already seen the structures in lab. And so there won't be a whole lot of new information here, honestly. And I'll back it up a little bit, and we'll go back to the formation of sex cells. The reproductive systems are in place, really, for the formation of the sex cells, or for the formation of the gametes. And in order to make the gametes, the cells have to undergo a special process called meiosis. And meiosis, you'll hear meiosis as well. And meiosis is a situation where you're cutting in half the amount of genetic information. And if it weren't for meiosis, each time fertilization occurred, you would be doubling the number of chromosomes, right? An egg with 46 would be matching up with a sperm with 46, and now we would have a higher number, 92, we'd have 92 chromosomes. So we have to get the number back to half, and so that when the egg and sperm unite, we're reuniting back to 46 chromosomes. In the process of making sperm, and what's that process called? Spermatogenesis. In spermatogenesis, one cell that begins this process ends up in 4 sperm cells, whereas in oogenesis, the making of eggs, the one cell ends up creating only 1 egg. And so the numbers here are significantly different when you think about spermatogenesis versus oogenesis. And then it's also at fertilization that the sex is determined of the child, and that is going to be based upon the presence or absence of the Y chromosome. And what you can do is line up all the chromosomes here. This is called a karyogram, looking at all of the chromosomes. And they're ordered here from number 1, the largest pair, down to the 22nd chromosomes. They're the smallest. And then after the little tiny 22s, there's also, in the corner usually, the sex chromosomes. Now this karyotype, this karyogram is telling us that this person has an X and a Y chromosome. They are a mismatched pair, and this individual would be male as a result of this. If there were 2 matching X chromosomes, this would be female. Now, one of those sex chromosomes came from the mom and one came from the dad. Well, the Y had to come from whom? Right, had to come from the father, because fathers have X and Y chromosomes to offer. Females only have 2 X's, and so that's all they can provide their offspring is an X chromosome. Now, there are some variations on this theme, and that's more of the conversation for a genetics course or another biology course. Remember, we talked about trisomy 21. Trisomy 21 caused what? If there were 3 of these little chromosomes there, this person would have Down syndrome, right? Down syndrome, a genetic issue where there's a 3rd chromosome 21. Now notice 21 is a very small chromosome, and so it is possible to survive with an extra chromosome, but you never hear about trisomy 1s or trisomy 2s. Those are huge chromosomes by comparison, and that's way too much genetic information. We as organisms cannot survive, honestly, with missing or extra genetic information. A little bit, it's okay, right? A little bit we can tolerate and still survive. And so a person with trisomy 21, that's a pretty small chromosome. Now, what are the ramifications of having that 3rd chromosome? These individuals have some mental challenges. They have some heart defects oftentimes. They have a particular look to them. So there are features that are that these individuals have as a result of the 3rd chromosome, number 21. So just to get an overview of spermatogenesis, this would be the first cell in the process, a spermatogonium. Where are these cells found? Where would spermatogonia, plural, be found? Where? I heard the testes, yes. Where in the testes? In the tubes, right? In the seminiferous tubules. And even more specifically, where in the tubules? Remember I showed you in the histology that if this were cross-section of a tubule, and in the center you have all the sperm coming into the center, right? Where were those spermatogonia? They were dark staining cells around the outside, weren't they? And they were the cells that were, quote, awoken by testosterone and started the process of making sperm, spermatogenesis, and those sperm were then dumped, if you will, tail first, into the lumen. And so what happens is that these spermatogonia, once puberty begins, undergo a meiosis 1 and then a meiosis 2. We're not going to get into the specifics of that. Just know that in the process of this, we start off with one cell, and we end up with 4 different genetically unique sperm. So that each fertilization is a unique sperm uniting with a unique egg to give a unique individual. So that's what the 23 and the 46 represent. 46 because these cells are what? What's the word? Diploid. And 23 being haploid, one set of chromosomes. So at fertilization, what happens? The egg and sperm are coming back together. This is a cartoon showing an egg in the very center. And that egg has, this is the actual egg cell, and here's this little nucleus. And we know that upon ovulation, that not only is the egg released, but it's released with a layer of helper cells or follicular cells around it. And that's what this is showing, is that as the sperm is coming in, it has to penetrate through those layers, those outer cell layers. And those, what is it that allows the egg, what is it that allows the sperm to penetrate through those layers? You remember at the very end of the head of the sperm, there's a little sac of enzymes? And that was called the what? Acrosome. Right, so the acrosome at the very tip, a little bag of enzymes found at the tip of the sperm, and that will be necessary. And as these sperm, you see, hundreds of sperm are trying to fertilize this egg. And the moment that the first sperm, maybe it's this one, I don't know. The moment that the first sperm penetrates through, there is an electrical chemical change that happens on the surface of the egg that basically prevents other sperm from penetrating. It blocks them. Now, why would that be important? I mean, we're talking milliseconds this happens. As you can get a sense in this cartoon, hundreds of sperm may penetrate or try to penetrate the egg at one time. What if 2 sperm were to penetrate the egg? What would be the outcome? Death. Because now what does that zygote have? 3 sets of chromosomes. 2 sperm and 1 egg, and it doesn't know what to do with it, and it will not be able to divide and make sense of that. It probably won't divide more than once or twice, and the embryo will not be able to survive. And so if there is polyspermia, more than 1 sperm penetrating, it is death. And so there has to be a mechanism in place to prevent that from happening, and that's true. It's exactly what happens. So when the first sperm enters, all is well. As soon as the first one enters, there's a change on the outside of the egg that prevents a second sperm from penetrating. Otherwise, death. Now, I heard the word twins. What would cause twins? What would cause identical twins? 1 sperm, 1 egg, creating 1 embryo. And that 1 embryo, early in development, just simply kind of splitting off into 2 genetically identical beings. And our development allows for those 2 early embryos to fully form into 2 individuals. Okay, identical quads would be the same thing. Those twins then divide themselves. We don't understand what causes that. What would cause non-identical fraternal twins? 2 eggs, 2 sperm. So 2 eggs are ovulated at the same time, and 2 different sperm penetrate and fertilize, and this allows basically siblings to be born at the same time. So here's a colored micrograph of this blessed moment where you see the sperm penetrating through the outer layers of the egg. And I know in lab I mentioned this. What would be in this area here? What gets centralized or focused or packaged in that area of the sperm? Mitochondria. Okay? So the mitochondria get stuck in what's called the midpiece or the neck of the sperm. And that does not penetrate in. Okay? Only the head of the sperm, the DNA, and the nucleus is going to make it into the egg. The rest of it, the mitochondria and the tail, will break off and not enter into the embryo. So as I go through the reproductive systems, a large part of this is going to be comparing and contrasting. You already know your structures. That's not a real challenge, the male versus the female structures. So as we're going through this, just confirm the structures and then be listening for compare and contrast differences in the numbers and in the mechanism of these two systems. So as we think about the reproductive systems as a whole, both of them are ensuring the sexual maturation of the individual. Remember, not only are we producing gametes, right? Now, what are the gametes? Right? The gametes would be egg or sperm, right? So this is the egg or the sperm being produced by the female or male reproductive systems. And remember, those gametes are not only producing, let me back up. What glands are producing these gametes? What's producing the eggs? Ovaries and the sperm from the testes. Not only are the gonads, these sex glands, making the egg or the sperm, but they're also producing hormones. Right? And these hormones are necessary for the sexual maturation of each of us. So the reproductive systems are going to assure our individual sexual maturation, our secondary sex characteristics, as well as the formation of egg or sperm. And these two sets of structures are actually derived from the same tissue. So that up to about the 5th week of fetal development, I shouldn't say fetal, embryological development, way up until about the 5th week, we are all the same sexually. There's a default mechanism, and we would all form as female if it weren't for the presence of the Y chromosome. So both the male and the female tissues come from the same chunk of cells within the embryo. So we're going to say that the male and female systems have homologous structures, or homologs, and they are developmentally equivalent, or at least come from the same place. So again, the sex organs, the primary sex organs, are the gonads, the ovaries or the testes, and these gonads are going to produce the gametes, the egg and sperm, or the oocyte and sperm. You'll see 3 words for egg. You'll see egg, you'll see ova or ovum, and you'll see oocyte, and they really are all equivalent for our purposes. So egg, ovum, ova, plural, or just oocytes. And remember that these gonads are both exocrine and endocrine. Right? They're both producing hormones, so they're endocrine, and they're both producing something, egg or sperm, which is released from the body. So that makes them exocrine as well. The primary hormones in the female, we've heard about them, estrogen and progesterone, and there are androgens, specifically testosterone, in the males. Now, women have testosterone, and men do have levels of estrogen, and those levels are just in vast different proportions. Where do the women get their testosterone? They don't have testes. So where's the testosterone produced in women? Anybody know? Testosterone is produced in small amount by the adrenal glands. Okay? So if a woman has an adrenal tumor or has an overactive adrenal gland, what might some of their characteristics be of this adrenal tumor? Lower voice, facial hair. Right? So some of the secondary sex characteristics that we think of as being masculine, lower voice and facial hair, would be indicative sometimes of adrenal tumors in women because they're overproducing that testosterone. Both of these male and female reproductive systems have accessory organs. So the primary sex organs are the gonads, the ovary or the testes. Everything else, all the plumbing, and all the other structures would be considered accessory organs. And those accessory organs, including the duct systems, are necessary for the egg and sperm to find each other, for fertilization to occur. And you'll hear about copulation, coitus, sexual intercourse. These are all ways by which fertilization can occur. I should put in there just good old test tube babies nowadays, right? 1979, Louise Brown was born. Anybody know who Louise Brown is? Louise Brown, a lovely British woman now. First test tube baby, right? First test tube baby, 1979. And then after that, it was worried that she couldn't have children herself. And I forget how long ago it was, but in the last 5 years or so, as I recall, I remember hearing that she has had her own children naturally. So there was this fear that these test tube babies would somehow be aberrant or abnormal or mutated or something. And we've proven that the egg and sperm coming together in a test tube or in some other non-natural way is absolutely fine as far as creating embryos. Now the gonads are going to be primarily non-functional and dormant up through the time of puberty. And then at puberty, when hormones are being produced, then the external secondary sex characteristics will become more prominent. That is breast enlargement, pubic hair, axillary hair. At this point now, the reproductive organs are becoming fully functional. They're producing the gametes, the egg or sperm, and we're producing at this point the sex hormones. Both produce the gametes. The difference in the numbers, though, we've already discussed. The female is producing only, on average, a single monthly egg. Now, there can be more than one, right, when there's fraternal twins. And nowadays, with fertility drugs, women are being treated to superovulate, that is, to release multiple eggs at once. Now, that's something different than what I'm describing here. I'm talking about just normal cycles, typically one per month. Males, in contrast, are producing hundreds of millions of sperm every day. Women are producing all their eggs long before they're born. Men aren't producing any sperm until puberty. Those gametes are stored for a short while in the epididymis and will either be broken down by apoptosis or will be released upon ejaculation. Okay, so the sperm will constantly being produced and will be, here I'm putting the word resorb, but basically they're being broken down. Think apoptosis. So this idea of homologous tissues, let me go through 4 of them here. Maybe I've got a 5th one to add for you. So if we're in the female, okay, the ovary and the testis, right, those are homologous structures, the gonads. The clitoris and the glands of the penis, the erectile tissues, are homologous structures. The labia major and the scrotum. So that fold of skin that goes around the scrotum, or that becomes the scrotum that goes around the testes, and the labia major are homologous. They're covering or protecting some of the organs. And then you've seen the bulbourethral glands in the male. What was the other name for those? Cowper glands, right? C-O-W-P-E-R. The Cowper glands or the bulbourethral. In the female, the equivalent structures are the vestibular glands. There's that word vestibular again, keep popping up in different places. What do the bulbourethral glands do? Remember, they are the pre-ejaculatory secreting glands in the male. Well, females have an equivalent gland, the vestibular glands. And again, these are going to be pre-ejaculatory lubricating glands. And they're found where? In the vestibule, that is the entranceway into the vagina. And I've got one cartoon image today to show you the location of those. Perineum. The perineum. This is a diamond-shaped region. If you spread your legs and draw basically a diamond shape, and it's going to be, this diamond is going to be bordered by the pubic symphysis on each side, by the ishiotuberosities, there's a term you haven't heard in a while, and then also the coccyx. And this big diamond that we can create can be broken down into 2 smaller triangles. There will be, and you'll see in the picture, there's the anterior triangle, which is also called the urogenital triangle, and there is the posterior triangle, which will include, or the anal triangle, which will include the anus in both sexes. Let's take a look at this perineum. So the female on the left, again, here's the diamond going from the pubic symphysis to the ischiotuberosities and to the anus. You can divide this diamond into two triangles. Here is the anterior triangle and the posterior or the anal triangle. In the male, same idea, from the base of the scrotum at the ischiotuberosity, at the pubic symphysis, down to the ischiotuberosities, and then back to the anus. Again, notice the width here. Average width of the pelvis for females is going to be wider than males, and this is to assist with childbirth. So we'll start off, this will be just female at the next few slides. And imagine if you were to compare the abdominal pelvic region or cavity of a male versus a female, really the only difference internally is the female has this uterus and a couple ovaries sitting down in the pelvis. And so this big muscular uterus is going to create a couple of dead end pouches that are pretty obvious in the model that you've seen. I just didn't label them in lab. And these two dead end recesses or pouches, the first is the anterior vesicouterine pouch, and you're going to see that it's formed between the uterus and the bladder. And then there's a posterior pouch, rectouterine pouch, between the uterus and the rectum. Of course, in the female, the primary sex organs are the ovaries, and everything else would be accessory. That's going to include the tubing, the ductile or the plumbing, the uterus, the vagina, the clitoris. And don't forget that the mammary glands are also part of the female reproductive system. They're part of nourishing the newborn, and we don't have any models of the mammary glands, and so we haven't been focusing on them. So you've seen this image before. Let me point out those two pouches. So the rectouterine pouch between the uterus and the rectum. So there's a dead end pouch right there, okay, that's formed. And then the other one, right in there between the bladder and the uterus, that's the anterior pouch or the vesicouterine pouch. And again, just imagine that would be the only real difference in the male versus the female abdominal pelvic cavity. Now, I'm going to erase this and then draw on this, and I want you to tell me, what am I drawing on? What is this layer that I'm drawing? Peritoneum, right? Do you agree that's the peritoneum? And so what is the bladder? The bladder and the kidneys aren't even in this view, but the bladder, and here's the ureter coming down, they are retroperitoneal, aren't they? And even the uterus is also what? Is it surrounded completely by a peritoneum? No, right? It has peritoneum going around the top, but it certainly doesn't going into the uterus. So there is a serous membrane, right? A serous membrane going around the outside of the majority of the uterus, but it certainly doesn't enclose it all the way around, doesn't go around the cervix.
Would the open space then contain the intestines up there?
Yes, absolutely. All this stuff up in here there would be digestive organs.
So the ovaries are among the intestines?
Absolutely, they'd be up there, not very far off from the large and small intestine. Absolutely. Absolutely. So let's take a look at some of the structures here, just as a quick review. I point, you tell me what I'm looking at. Clitoris. Let me get to a different color here. The smaller fold of skin. Internal, more the minor labia and the major labia. This opening is the anus, right? Here the vagina, and here the urethra. This is the bladder, and this is the uterus. The part of the uterus that projects into the vagina, the neck-like structure, is the cervix. Little finger-like structures are the fimbriae through the uterine tube, oviduct, or fallopian tube, all the same. And the white structure here is an ovary. Good. The uterus and the ovaries are held in place within the female abdominal pelvic cavity by a broad ligament. You saw this in lab as well. There's also some suspensory ligaments that are going to hold the fallopian tubes up here, and that broad ligament is going to protect in part the ureter as well as the uterine artery, the uterine vein. You can see now the projection of the uterus, the narrow region, the cervix going into the vagina. On here you can also see that there's a fallopian tube, but there's also a ovarian ligament that connects the ovary to the uterus.
Does that connect to the uterus itself or to the perineum?
To the uterus itself. Yeah.
Goes through.
Yep. So tell me about the egg production. You guys know this story. Eggs are produced in the female when? When do they begin their journey? They begin their developmental journey way back in fetal times, don't they? And so basically back in the ovary, in the cortex, in the outer layers of the ovary, this is where the oogonia are found. Now the oogonia, same term, similar to the spermatogonia. These are the stem cells, the first cell that will begin making eggs. And they are found in the cortex of the ovary. And because these cells need to be protected for decades, they're going to be protected or surrounded by follicle cells. Together, we're going to be creating follicles. So the egg inside a bunch of follicular cells will be collectively called a follicle. And in early development, from fetal development through puberty, all that you'll find around the cortex of the ovary are these primordial follicles, these very immature follicles. Upon puberty, what happens? Some of these primordial follicles are awoken, if you will. They begin to be hormonally turned on, and they begin to go through different stages of development. In this process of oogenesis, some of those primordial follicles will become secondary and go on, but only one will usually make it to the end. I'll retell that story here in a moment. So the process of oogenesis begins way back in fetal development. Again, here's that word. The cells are oogonia. And they are diploid cells. Just like I showed you, the spermatogonium had 46 chromosomes. So too do these oogonia. So they have 23 pairs. And again, they're going to stop very early in the process of meiosis in an early stage called prophase. We won't break this down, but just know that they're getting stopped very, very early in primordial, or in development. When a female child is born, she has about 1.5 to 2 million of these primordial follicles. Okay? So that's it. That's as many as she'll have, whereas guys are making hundreds of millions of sperm every day. Right, a woman is going to start off with a maximum of somewhere to 1.5 to 2 million of these follicles. And they're going to stay, again, in a state of suspended animation all the way through puberty. And then beginning at puberty, some of them will begin to wake up or be pushed along developmentally. The thing is, though, is that during life, there are many of these follicles regressing or being broken down, and that process is called atresia. So there's a natural atresia occurring. So while a woman is born with 1.5 to 2 million of these follicles, by the time she reaches puberty, there's only about 400,000 or so left. Okay? Now, how many eggs will a woman release in her lifetime? 400,000. Is that enough? How many eggs will a woman release in her lifetime? Give me some estimates. Let's just say, for the point of easy numbers, that a woman is going to be menstruating from the time she's 10 to 50. Those are roundabout numbers. So 40 years of reproductive cycling. And how many, right, so 40 years, and how many per year? 12 to 13, right? So 28-day cycle, that's actually 13. So what are we talking about? 500-ish, right? Somewhere around 500 eggs is all that a woman will release in her lifetime. Okay, that's a lot of cycles, right? Because the first few cycles early in teenage years, there isn't always an egg released at the end. And as a woman reaches toward menopause, sometimes there's some months where an egg isn't necessarily released either. So we'll just say 500, okay, as a rough estimate. Now what's going to happen is that at puberty, there's going to be a hormone released from the hypothalamus. And I will ask you to grab these hormones and make sense of this story. So the hormone that's going to begin this whole thing, released by the hypothalamus, is called GnRH, gonadotropin releasing hormone, GnRH. Now, what does gonadotropin mean? We just had tropic in our vocab. It was the first slide. I messed up, right? It was on your last vocab. It was supposed to be on this one. But tropic means what? Influencing. So gonadotropic or gonadotropin must be what? A hormone that is going to influence tropin, the gonads. So this gonadotropic hormone, GnRH, is released from the hypothalamus, and it's going to tell the anterior pituitary to release two hormones, follicle stimulating hormone and luteinizing hormone, FSH and LH. You may have heard of those two hormones, FSH and LH. Follicle stimulating hormone. Okay, what's it sound like it's going to do? Stimulate follicles, right? The egg development. It's going to further development of and cause the release of an egg. And luteinizing hormone, we'll see the corpus luteum show up in a few minutes, and we'll make that connection with luteinizing hormone. The levels of FSH and LH are cyclic. That is, they're going to be changing on a monthly cycle, and they peak on a monthly cycle. And this cycle involved with the ovary and these hormones is called the ovarian cycle. And there are three parts to the ovarian cycle. There's the follicular phase, the moment of ovulation, and finally the luteal phase. Okay? So follicular phase, ovulation, and luteal phase. Let me break this down for you. So we're talking about the ovary, right? Ovarian cycle. So the first 13 days, and I'm going to say this is a 28-day cycle. Okay, so women have shorter cycles, some have longer cycles, some have irregular cycles, but we'll use 28 days as an average. So of a 28-day cycle, the first 13 days will be the follicular phase. Sounds like what might be happening? Follicles are developing or continuing their developmental journey. And what happens is that about 20 of the primordial follicles will begin the journey. Now, only one will make it to the end, typically, but 20 will start. Then, on day 14, the one that wins the race, the one follicle that makes it all the way to be the one released, will be released, and this happens right smack in the middle. So day 14 out of 28, right in the middle point, that's the moment of ovulation, and now the ovary will release this egg. Again, typically only one. Now, after the ovulation occurs, then the ovary is in the luteal phase. And this is from days 15 to 28. And this is the time after the egg has been released. But what happens is that those follicular cells, those follicle cells that were wrapped around the egg that was released will become the corpus luteum. And that corpus luteum will itself begin to secrete hormones, specifically progesterone and estrogen. Right, so the hormones, estrogen and progesterone, are being produced by the corpus luteum. Now, what these hormones are doing is they're sending a signal to the uterus saying what? They're sending a signal to the uterus to stabilize the uterus, because an egg was just released, right? An egg was just ovulated, and it might become fertilized. And if it does, then that embryo is going to need a place to hang out for 9 months. And so it's sending a signal to your uterus saying, hey, stabilize and build up that uterine lining so that the uterus can prepare for possible implantation. The corpus luteum will typically only survive for 10 to 13 days. Okay? If the egg is not fertilized. And so if it's not fertilized, the corpus luteum will regress and becomes the corpus albicans, think albino, the white body. At that point, it no longer secretes hormones, and that will now lead to the shedding of the endometrium and beginning of bleeding menstrual cycle once again. If instead the egg is fertilized, then the embryo itself will start to produce HCG, human chorionic gonadotropic hormone. That is the hormone used in EPTs, early pregnancy tests. Okay, so EPTs, early pregnancy tests, pick up the presence of HCG. And that is, the levels are detectable in the urine. And so you can urinate on the little test and it will tell you if there's any HCG in the body, and if so, then the woman is pregnant. That's the early pregnancy test. Let's take a look at the ovary. Let's take a simple look at a cartoon slice. So we're looking in the ovary, and this is very simplified again, but there is, around the outside edge, all of these follicles. And we'll start right here. Those are the little tiny, tiny primordial follicles. There would be about 1.5 to 2 million of those around the cortex of a newborn ovary. Only about 400,000 of those left in a puberty, right, going into puberty. And every month, upon hormonal signals from that GnRH, and follicle-stimulating hormone, about 20 of these primordial follicles are going to begin a developmental journey. Of those 20, though, and for reasons we don't completely understand, only one makes it. And I know why, but it's outside the scope of this course. Just know that of the 20 or so that begin, only one will finish the journey. And that one becomes the mature, and this thing has 3 names. It's called the mature, or the tertiary, or in this case it's called vesicular. All 3 of those are the same thing. So the mature, the tertiary, or the vesicular follicle. It is the big one. It's the one that is going to release, right? And it's this one mature follicle that on day 14 will undergo ovulation and release the egg. So how long did this take from here to here? About 13 days. Right, that follicular phase. 13 days to start from the beginning and go all the way to development of the Graafian or the vesicular or the mature follicle. And then on day 14, it's released by ovulation. Around the outside of that egg, you can see that there's layers of cells, and those are the layers that the sperm must penetrate through to fertilize the egg, and that's why the acrosome is so important, because it has to penetrate through those outer layers. The cells that are left behind. So this stuff left up behind is going to become the corpus luteum, right? The yellow body. And it's this corpus luteum, what's shown in yellow, that is going to secrete progesterone and estrogen for the next 10 to 13 days. And then finally, after those 10 or 13 days, it'll regress, stop making estrogen and progesterone, and regress down to what's called the corpus albicans, the white body. No longer making hormones, and so as a result, the uterus begins to slough off the inner lining again. So this is going around, round and around and around in the ovaries. It's not necessarily always taking turns. It can be the left, then the left, then the left, then the right, then the right, then the left. Ovary, it doesn't have to be alternating. It's not perfect. But one of the ovaries every month is sort of ahead of the other one and takes charge and continues down this process. If the ovary releases 2 eggs, or if both ovaries release an egg, then that's when fraternal twins are possible. Questions anywhere on just the basic ideas of the ovarian cycle? First 13 days, what's going on? Follicular formation, it's called the follicular phase. Day 14, ovulation. 15 through 18, it's 15 through 28, the corpus luteum is formed, so we call it the luteal phase. Okay? So just as a quick reminder of the overall process of oogenesis, right? We have a diploid cell in the cortex of the ovary called the oogonium. It begins meiosis, but gets stuck very, very early, and that forms a primordial follicle. These primordial follicles are sitting around the outside edge of the ovary in that cortical region and doing nothing for the next 10 years plus. Under hormonal signals, they will begin a journey, about 20 of them every month. And so about 20 primordial follicles will begin to mature into primary follicles and then go to secondary and then finally go to tertiary, vesicular, or mature. I'm not going to ask you which one's which in a picture, right? They're all follicles. And
I had a hard time following that slide.
so this is saying what's happening before fetal development. So before a woman's born, she will have made all these primordial follicles. The pink region is childhood, nothing's happening. Upon puberty and all the way through until the woman stops cycling, she will about every month start about 20 of these primordial follicles along this journey. Of that 20, only one will make it to be the mature follicle. That mature follicle will be released on day 14 of the cycle as ovulation. And then that egg has the potential of being fertilized and forming an embryo. Nancy, what else?
I was wondering, am I supposed to go back and forth when I read that, or is it straight down?
Understood. This is what's going on in the egg as far as genetic material, and this is what's going on as far as follicle development. So they're parallel.
Okay.
They're parallel. So, and this is kind of going through stuff we haven't discussed because we haven't gone into the details of meiosis and all that's going on.
I think that's why it confused me.
Yep, I can see that. So do this for me. Do take this pathway. We start with the oogonium. We start with meiosis, and we make primordial follicles, and then this is what happens over here. Okay, and don't worry about over here because I really haven't broken this down into a genetics study. So the woman will continue to have the cycling of the hormones and will continue to release an egg on average every 28 days until she gets to about the time of perimenopause. Peri meaning around. So perimenopause is the time before menopause. Estrogen levels are beginning to drop, and the woman may start experiencing some irregular periods or some very light periods. And eventually, the woman will stop having menstrual cycles altogether. Menopause, by the definition I'm using, would be after a year of no cycling, and you're not pregnant, then you are truly in menopause. So the hormone levels have dropped off, there's no more cycling. I was going to say, you're not Mrs. Duggar, right? I mean, how many cycles has that woman actually had in her life, right? There just aren't very many, right? 21 kids and 19 kids, whatever it is, and almost always pregnant, right? Not much break in between. This menopause is usually going to, perimenopause and menopause are going to kick in somewhere in the 45th to 55th year. And again, what's going to happen during this time is you're no longer going to be having the estrogen and the progesterone, no longer any cycling, so no longer endometrial changes of the uterus, no longer any bleeding cycles, no more ovulation. Now, what else happens, though? I don't have any slides on this, but what happens with those dropped estrogen levels? Women start complaining about what? Hot flashes, other, hormonal imbalances. And so right now there's a real big movement, if you will, to minimize those side effects by taking estrogen supplements post-menopause. What's one of the problems with that, though? Breast cancer. Breast cancer, the numbers are about 1 in 8 women will experience breast cancer in their life. And we know that many breast cancers just love estrogen. And so a woman who is being given estrogen supplements actually is feeding the tumor. I don't know that, there's no evidence that I know that it's causing the cancer. It's not that the estrogen is causing the cancer. It's just that if that woman is prone and does develop breast cancer, the estrogen that she is taking as a supplement is going to sort of speed along that cancer. Okay? So it's not that the estrogen is causing the cancer. And now we're dealing with testosterone in males. That's the big thing on the news, right? So men now are getting testosterone patches and testosterone replacement protocols. So we'll see what the ramifications are of that in the next 10, 15 years. So let's talk about the uterine tubes for a moment. Back to structure. These are the uterine tubes, the fallopian tubes, or the oviducts. They're traveling laterally from each side of the uterus. And it's through these that the embryo, or the egg, is going to travel. It's also in the uterine tube where fertilization normally happens. Now, Saladin used the word, and I don't like the word, but it used the word pre-embryo to describe the embryo before it reached the uterus. It's still an embryo, right? So the embryo is going to go from the top of the fallopian tube, and I'll show you a picture in a moment. And typically it takes about 5 or 6 days for the embryo to reach the uterus. Okay, 5 or 6 days of traveling down the fallopian tube. In fact, I want to go back to that quite a ways up, just to give you the big picture here. Actually, this might be the better picture to show you. So typically, the egg is released and caught by the fimbriae. And the egg will only be able to be fertilized for about 24 hours. So that means that sperm have to be there within 24 hours of ovulation, either before or after, right? Because the egg's only viable for 24 hours. The sperm are going to be coming up, right, going up the fallopian tube, and could either have been present for 2 or 3 days before, because sperm are good for 72 hours. Okay, sperm are good for 3 days. So that means that the sperm either were introduced into the vagina and up the fallopian tube 3 days before ovulation, or shortly thereafter, right, within 24 hours of ovulation. So fertilization usually happens up here. And then it takes 5 or 6 days for the embryo to make it down the fallopian tube and to embed into the uterine wall. Okay, 5 or 6 days for that journey.
Their pregnancies occur outside of the fallopian tube, like.
It is very, very possible. I'll talk about ectopic pregnancies in a moment. Oh, I can do it now. So if for some reason during that 5 or 6 day journey the embryo gets stuck in the fallopian tube and tries to set up shop in the fallopian tube, then that's an ectopic pregnancy. And what can that embryo do? Can it survive? No, there's no uterine lining, there's no possibility for the embryo to survive there. But what it can do is start causing a lot of pain to the female, and rupturing of, in the worst case scenario, can rupture that fallopian tube. And that can lead to further scarring in the future. So any scarring at all in there can lead to that problem, and then if we rupture it, it makes it more difficult. It's also possible, I don't think there's any numbers on this, but the sperm can certainly go right up and through and out into the abdominal pelvic cavity. And it's also very possible for the egg to release the egg at ovulation and not for it to get sucked up into the fimbriae. And so it's also possible for fertilization to happen out in the abdominal pelvic cavity. Now, that embryo wouldn't have any chance of developing. There's no nourishment out there, but there'd be no pain, right? The woman wouldn't know it because there's no ectopic pregnancy occurring. There's no pushing on the uterine tube. So it is possible. I don't know how often, but we know it's possible for fertilization to happen out in the abdominal pelvic cavity, and the woman would never know it.
Do
HCG levels would elevate, but not for very long because the embryo is not going to survive very long. Yeah. So I don't know. That's a good point. I don't know if there would be any. It's already a very rare event anyway. and then how much of a false positive test might show up in a very, very early pregnancy test, right? But those numbers wouldn't pan out over time.
And then does that all flush out of the system?
It would just be taken away. The macrophages, the immune system of the body would say, hey, you don't belong here. And the embryo would not survive, and so it would just be destroyed as part of the immune system. Okay, so if we're dealing with, we talk about the uterine tube, bringing the egg down, and possibly it's been fertilized, coming down with an embryo, and then it would reach the uterus. The uterus really has four purposes. Number one, the site for implantation. It's where the embryo is going to hang out. It's going to protect that embryo and later the fetus for 9 months, and it's here that the placenta will develop. The placenta is a necessary connection between the mother and the baby for nourishment and oxygen and everything else. The egg is pretty large, right? It's the largest spherical cell in the body, and it contains in its own little yolk sac, just like a chicken egg has a yolk sac. That yolk is sufficient to sustain life and nourishment for the days of gestation of an egg. The human, that yolk sac is only good enough for energy until implantation can occur, and then the placenta will begin to supply the nourishment. Okay, so that we do have a yolk in the human egg, and it lasts for just a few days. It's also the uterus that is going to get very muscular during pregnancy and will begin to contract when a hormone called oxytocin is released from the brain. So oxytocin is what is going to initiate labor. In the clinic, we give people Pitocin, right? Pitocin is basically an analog of oxytocin, and that usually is given to push the uterine contractions along. And then finally, the uterus is the site of menstruation when there isn't an embryo, this monthly shedding of the inner wall. Now, the uterus has 3 layers. You shouldn't be surprised by tunics. Names are very easy. The perimetrium, the endometrium, and the myometrium. So what would the perimetrium be? Peri meaning what? Around, right? So around the outside, if you will. That's the outer layer of the uterus if you were to touch it from the outside. And then the majority of the uterus would be a muscular layer called the myometrium. Remember that core, METR, meaning uterus or womb. And then the endometrium would be the inner layer, and this is the layer that is sloughed off on a monthly basis. So again, the perimetrium, you can think of it as being a serosa, part of it anyway, is a serosa, because part of the uterus is surrounded by a serous membrane, not all of it. And then the myometrium, that thick layer of muscle. During pregnancy, the uterus gets, the muscle cells get bigger in size and in number for that childbirth event. And let's talk now about the cycling of the uterus. So this is the uterine cycle or the menstrual cycle. And it's going along with the ovarian cycle. So we got to keep these two things separate in our mind, but also see what the connections are. So the menstrual cycle is going to be just the first 5 days of the uterine cycle. This is the phase of bleeding. Then there's going to be a proliferative phase. This is a time where the uterus, specifically the endometrium, the inner layer, will be building back up. And the proliferative phase will be from days 6 to 14. Now, what's going on during this time in the ovary? 14 represents what? Ovulation. So this is that time, this is all part of that what? Follicular phase, right, where the follicle's forming. And at day 14, what happens? Up in the ovary, the egg is released. Okay? So we've got this proliferative phase where we're building up, and we're anticipating the arrival of the embryo. And then the last days are called the secretory phase. Now this is day 15 to 28. What does that correlate with up in the ovary? 15 to 28 was also in the ovary called the luteal phase. Okay? And let's take a look at this together, put these two things together and figure this out. Again, if the oocyte is not fertilized, if the egg is not fertilized, remember that corpus luteum is formed, and is there for how many days? The corpus luteum will hang around for about 10 to 13 days. And then if nothing's going on with the egg, then it will degenerate, the hormone levels will drop off, and it will become the corpus albicans. And then we start the whole cycle of the uterus again. So here's a slide you haven't seen, and I wish I could take this slide and put it on top of the next slide. But let's put all this into perspective right now. The top is the gonadotropin hormones, FSH and LH. Where were those hormones made? FSH and LH were made in the anterior pituitary. And they're released, and all I want you to see here is that they spike, both of them. Look at them. They both are going to spike right where? Right before ovulation. That's all I want you to see. Right? That there's a cycle going on here, and that the FSH and the LH both are going to spike, especially the LH, are going to spike right before ovulation. There are some pre-ovulation kits that are available that will time ovulation for couples trying to get pregnant. And part of what they're measuring is temperature, but also these hormones, because they're spiking right beforehand. And if intercourse happened right there, that'd be a good success, wouldn't it? Because the sperm are released, they're good for 72 hours, the egg's going to be released at 14 days, and that'd be good timing. On the bottom, right, we're up in the ovary. So again, follicular phase, the first 13 or so days, day of ovulation on day 14, luteal phase after that. On the bottom, this is, okay, so this was happening in the ovary, right? We're in the ovary. Down here, we're in the uterus. These are the ovarian hormones. So this is estrogen and progesterone. Who's producing them? The ovary. What's their effect on the uterus? Back up. The FSH and the LH were made by what? The pituitary, and they had their effect on the ovary. And then the ovary is making estrogen and progesterone, and it's having its effect on the uterus. So what the endocrine system does is one system secretes a hormone, it travels through the blood to a far, far distant place, has an effect. Now what are we going to see here? Estrogen. All I want you to see is this. Estrogen goes up in the proliferative phase, and it comes back down. That's all I really want you to see. Estrogen is rising in the proliferative phase. And then look what happens in the secretory phase. Progesterone goes up and stays up. Okay, so I want you thinking about progesterone here and estrogen here. Estrogen rises before ovulation. Progesterone rises after ovulation. Estrogen before, because here's day 14, right, where they kind of cross, right in this area. So estrogen is high before ovulation. Progesterone is high after ovulation. So those are the hormones. Now let's see what's going on. On the top, again, we're in the ovary. The first 14 days. What were the first 14 days? It's not marked. The follicular phase was the first 14 days. So we're forming follicles, aren't we? On day 14, that was ovulation, wasn't it? And then the rest of it was called the what? The luteal phase. And that's when the corpus luteum is going on. What's happening in the ovary at the same time? The first 5 days, menstrual flow, menstrual phase. Then there is a proliferation, a building up of the uterus, specifically the endometrium. And then there's the secretory phase. What's being secreted? Go back. What was primarily being secreted during the secretory phase? Progesterone from the corpus luteum. So the corpus luteum is now producing progesterone, and that is maintaining the uterine lining. If you look at the curve, Again, I wish I had the previous slide in this slide. I'm going to wipe this clean. If I had that previous slide, what's happening right here? I'm going to change colors. What did it say was happening right here? And I think it was green. And right here. What hormones were spiking right there, right before ovulation? FSH and LH. I don't remember which one's which, right? Luteinizing hormone was higher, right? So FSH and LH were spiking right before ovulation, weren't they? Then what did you see down below? What was happening here? Estrogen, right? Estrogen was high. And it went down, and it kind of spiked again, but I'm not going to worry about that. And then what did progesterone do? Progesterone came in and did what? Flat, and then kind of went high, didn't it? Progesterone almost mimics the lining of the uterus, doesn't it? So progesterone is low down through here, and then it starts to go up as it begins to get really thick in the endometrial lining. So that's your progesterone. So I do want you to figure out, kind of superimpose those two images, you know, and that's what I've kind of done here, just to get an idea of what's happening with these hormones and what's happening in the ovary and what is simultaneously happening in the uterus. Here are those two cycles side by side, so day-wise. So what's going on in the ovary versus what's going on in the uterus, and breaking it down that way. If you can put all this together in one mental slide, you'll be in good shape for what I need you to understand this semester. Yes, ma'am.
I have a couple questions. The first one, probably the easier one, is the progesterone. It looks as though it goes down. Why do some women need progesterone injections throughout, like, the first several months of their pregnancy?
Right, because what you're saying, okay, so the question is, why do women need progesterone shots, some in early pregnancy? It has to do with, my understanding of it, is this progesterone level starts to come down. And it comes down because what's regressed up here? The corpus luteum, right, has regressed in the ovary. And that usually regresses down to the corpus albicans and no longer makes the progesterone. And so if there isn't enough progesterone, what would happen to the woman's lining? It would slough off and begin menstruation, right? So in some women, they're more sensitive to this change, and after repeatedly not being able to get pregnant, or maybe after some miscarriages, they might give them some progesterone, and that might help to keep the uterine lining as ripe and as viable as possible to help maintain that pregnancy. Okay.
And then with the corpus luteum, I guess I don't understand what that is. Is that?
Okay, what is the corpus luteum? Let me go back to that picture. So actually, I'm going to go back to that ovary slide. The question is, what is the corpus luteum? Actually, no, this one's good because it shows the timing. What is happening? Let me tell you the story and then tell me if it makes sense. What's happening right here at day 14? Ovulation. And so at this point, the uterus is proliferating. It's getting good, but remember I told you it's going to be how many more days from ovulation until the egg, or the, quote, the embryo would reach the uterus? 5 or 6 days. So day 14 plus 5 or 6, now where are we? Day 21. By the time that embryo would reach the uterus, now look, the uterus has reached its most vascular, richest, deepest, lusciousness at all. And so there's your 5 or 6 day gap. What's going to tell the uterus to keep proliferating? I mean, we're saying proliferation stops here, but now so at ovulation, okay, this is the egg released with those follicular cells around it, the cells that were just on the inside here. But all these other cells that are forming around this large Graafian or mature follicle, those are the cells that become the corpus luteum.
So those are considered follicle cells or no?
They are.
Okay.
They are. They're all part of the follicular cell. So what happens is that during development, so let's take a look at this. And again, I don't want to get outside the realm of this, but I want you to understand enough of it so the story makes sense. So primordial follicles sitting there since fetal development, waiting for puberty to begin. Upon puberty, about 20 of those, there'll be thousands of them, about 20 of them begin a journey and become primary follicles. And of those 20, it gets less and less and less, and only one will make it to the mature follicle. The other ones regress and kind of fall off the developmental bandwagon. And then that one is mature. The egg will be released upon ovulation with the little bubble of cells around it. But the other cells, because this thing gets really, really big, the other cells that were sitting around the outside edge here will become the corpus luteum. And they themselves will become endocrine and start producing the hormones. So if you looked at an older ovary, you would see many corpus albicans. If you looked at an ovary that had never gone through puberty, you wouldn't see any.
So then the membrane of the ovary, I guess I look at it and think it just like.
The membrane out here,
cells, they just-
it literally gets ruptured. It pops out and ruptures. It's rather a violent ejection. They have actually, I don't have a video of that, but there's some really cool videos of the egg ovulating. And it literally is the outside of the ovary ruptures and spits out this ovary, and then it kind of heals up on the outside edge. Yeah.
That helps me.
It's not easy, right? It's not easy to imagine this. So I just want to get you, to the point where you can understand the overall story, and then we'll pick up the story a little bit more in detail next semester. Okay, so just if you're struggling with the hormones, the 5 hormones that you need to know are listed on this table. So the name of the hormone, where it's produced, and what it's doing. So what do we have here? Gonadotropin releasing hormone. It was made in the hypothalamus and initiates this whole thing of puberty. It also initiates the monthly cycle. But the hypothalamus only goes down and talks to the anterior pituitary. In response to GnRH, the anterior pituitary now makes FSH and LH. And the FSH is going to be involved with developing follicles, and LH will be involved with stimulating ovulation. We saw the peak right before ovulation. And then the estrogen is going to now, remember we saw estrogen primarily before ovulation, and we saw progesterone primarily from the corpus luteum and during pregnancy from the placenta. So the HCG and the placenta are also making progesterone, and those levels are all going to help maintain the uterus. I'm always reminded when I tell this story is that when we were pregnant between our first and second daughter, we had a miscarriage. And one of our best buddies, one of our best friends, was our OBGYN. So my wife goes in, it was a Friday afternoon, and he says, oh, let's have fun. Let's just take a look with the ultrasound, like maybe 8 or 9 weeks, really early. And no heartbeat. So at that point, so that was a Friday afternoon, and so he drew some HCG levels, right, because the HCG levels are made by the embryo, and they should go higher and higher and higher during early pregnancy. And he said, we'll do another sonogram on Monday. So we went back in on Monday, and sure enough, no heartbeat, and the HCG levels had dropped. So the HCG levels should continue to go up, 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 up during pregnancy if the embryo is viable. So the embryo, the baby had already died, and what would have happened a week later, 2 weeks later? If we had never done a sonogram, then yeah, she would have started she would have started bleeding, right? Because what would have happened? The HCG levels would begin to drop off, and the progesterone levels would begin to drop off from the placenta, and overall, the uterine lining would start sloughing off along with the baby. And so she would have gone into a spontaneous miscarriage. And so we went ahead and planned on doing the DNC, but basically we would have never known that, right? But it's sort of the same idea. So the HCG level should be rising, right? From the early pregnancy test, each time you go in, the HCG levels, they check them, they're going higher and higher. If they're going higher and the early sonograms all look good, then everything is, we assume, normal. Right? But if the HCG levels start to drop off, or they do a sonogram or something, obviously, and they see a problem, then once that embryo is no longer viable, then the HCG levels will start to drop off. And then the progesterone levels will drop, and so will the endometrium will start to slough off, and the woman will experience a miscarriage. Continuing down the story, vagina, just a couple more structures here. So the vagina is a fibromuscular tube. It's the birth canal, of course. It's the site of copulation and the passageway for menstruation. Lots of blood vessels and lots of lymphatic structures. And it makes sense. The female would have opportunity for infection through the vagina, so you would expect a lot of lymphatic activity here. And there is layers of the vagina, the mucosa, the muscularis, and the adventitia, just like we saw with the bladder. External genitalia, all that you can see in the female externally is called the vulva, right? And that's going to include the mons pubis, which is the hairy area where the pubic hair is sitting on top of the pubic symphysis. It's also going to be the labia major, the labia minor. So what you can visibly see in the female collectively is the vulva. The clitoris will be located in the anterior regions of the labia minor. And the clitoris, again, is homologous to the penis as far as the glands. The tip of the clitoris. And the prepuce is basically the little fold over the labia minor is also similar to the foreskin of the penis. Taking a look at this picture is the only place I have anything that shows the vestibular glands. So there is a small opening here for the vestibular gland or glands. And these, again, are pre-ejaculatory secreting that are homologous with the vulvourethral glands. Opening for the urethra, and again, the vestibule, just that generic word used to describe the opening into the vagina. And the prepuce over the clitoris would be similar to the foreskin on the penis. In childbirth, although not as common anymore, episiotomies were done. And this was to open the vaginal canal during childbirth to allow for the baby to pass without causing any damage. It was thought that a surgical incision was better than cutting or any kind of rupturing of anything. A lot of times, though, if the baby's big, now we just do C-section. So we don't see as many episiotomies anymore. And don't forget the breast is part of the female reproductive system. No specifics here. Just remember that there are quite a few lymph nodes. These are the axillary lymph nodes, which are associated with the breast. That's it for female. Let me take a quick break. We'll come back and talk just for a few minutes on the male and entertain any questions that you might have. Okay, so that's everything to do with the female. Anything at all in the female reproductive system? Structures, hormones, figuring out the cycles, anything in there? You're not an expert by this by any means, but you have a basic idea of the days and the names of the cycles and what's going on in each. Any questions at all? Okay, we're going to finish up the last few slides. I'll tell you right now, I'm not going to get beyond slide number is that? 58. I'm not going to go into syphilis. So I can tell you right now, we're going to stop at syphilis, and I'm going to get through the semen slide. And we're not going to talk about syphilis or chlamydia. And I will jump to the very, very last two slides that talk about the aging of these systems. But we'll jump over the STIs and over the birth control stuff, and we'll just jump from semen over the STIs and get to the last two slides, and that'll be our content. So there won't be anything on the sexually transmitted diseases on the exam.
That was my question.
Yeah, gone, right? Not of concern. So just so you know, you're looking and saying, man, we have a lot to do in the next half hour. It's really okay. Much of what I'm about to say you've already seen or heard. So now we're talking about the male reproductive system. Of course, the primary gonads for the male are the testes. Everything else are accessory organs, including all the plumbing. And this will be the vas deferens and the penis. Everything else is accessory. So we look at the structures. We know this from our model. We know this in preparation for the lab exam. I'm going to point. You tell me what I'm pointing to. Testis, one of them, testis. Two of them, testes. This comma-shaped thing is the epididymis. Upon ejaculation, sperm will travel through the vas deferens, also called the ductus deferens, and will now merge, go right past this gland. This gland is the seminal vesicle, and will merge with the seminal vesicle through this duct, the ejaculatory duct, and then merge into the urethra. There's a small part of the urethra right below the bladder that only carries urine, but the majority of the urethra would carry both urine and semen. There's a small portion, well, I should say, back up. This gland is the prostate. This little pushpin looking thing is the bulbourethral gland, or the caliper gland. And it has its own little duct to secrete pre-ejaculatory fluids into the urethra. And then we're going down through the urethra. On each side, there's a cylindrical structure around the urethra called the corpus spongiosum. So the spongiosum is going around the entire urethra. And then this larger area up here, this is another blood-filling region. That's the corpus cavernosum. And there are two of them, cavernosa, plural. And they are also important for erection. Going around the testis, right, the scrotum. And the scrotum, remember, is homologous with the female labia major. Over here, the anus, two muscle layers, two anal sphincters. Remember, there's also going to be two sphincters for the urethra. There's going to be one above the prostate. What would that be? The internal sphincter, smooth muscle. And then the one at the base of the prostate would be the external sphincter. Good. The scrotum, it's important that the gametes are produced at a lower temperature than body temperature, which is why the testes are found outside of the body cavity, contained within the scrotum. And if the testes stay within the abdominal cavity, I forget what percentage, but it's not uncommon for boys to be born with an empty scrotum, and the testes have not yet descended. And if they don't descend, they may give the baby a little shot of hormones. And if that doesn't work, then they will have to go up and surgically lower those testes down into the scrotum. And the reason is it will actually damage and prevent, the boy would be sterile if the testes do not descend down. So there is a muscle along the testes called the cremaster muscle. And the cremaster muscle is going to help regulate the body temperature and the sperm producing temperature. And it's going to push the testes closer to the body, or pull the testes closer to the body when it's cold. And it's going to relax and move the testes away from the body when the testes are too warm. So there's two muscles here. The cremaster muscle, again, is going to pull up on the testes. And there's also a dartus muscle that is going to be around the scrotum, and that is also going to either kind of wrinkle or relax around the scrotum, and that's also going to be part of the temperature regulation story with the testes. So the scrotum is outside of the body itself, if you will, and again, go through this with me. So this is the testis. This is part of the epididymis. Then going through this area, there's an opening right here in the inguinal ligament that's referred to as the inguinal canal. And in this space, what's passing through here? The vas deferens is passing through there, testicular artery, and a cluster of veins called the papiniform plexus. Now the papiniform plexus and the testicular artery and the vas deferens are all collectively referred to as the spermatic cord. Right, spermatic cord, everything going in and out, up and through the inguinal ligament, down into the scrotum. Now, why do you think there has to be a series of veins going through? Why do you think there's a papilliform plexus? We usually think of a plexus as being a group of nerves. In this case, the papilliform plexus is a group of veins. But why would there need to be a group of veins passing through the spermatic cord? Any hypotheses? Well, the blood is leaving through the papilliform plexus, right? It's coming in through the testicular artery.
I guess I meant for the erection.
For erection, yes, but that's not the purpose yet. That blood coming in the testicular artery is body temperature, isn't it? It's warm. And what have I told you? The sperm need to have a cooler temperature. So what do you think's happening as that warmer body blood is coming down and it's passing by a series of veins? Those veins are going to be, by their very nature, cooler. And what are those veins going to do? Cool down the blood's temperature. So as the blood is coming down the testicular artery, it's going to be cooled in that transport down through the spermatic cord such that the warmth will not reach the testes. Okay, so it's just another mechanism of coolness. So we've got the dartus muscle, the cremaster muscle, and the papilliform plexus, and the location of the testes in the scrotum, all contributing to making sure that spermatogenesis is happening at a lower temperature. There's also passing through the spermatic cord a testicular nerve. So nerve, artery, cluster of veins, and the vas deferens all are part of the spermatic cord. Just a dissected individual here, so you can see the scrotum's been opened up to expose the testes. Right, so the scrotum's been opened up here. I just think it's always cool that the sperm are leaving the testes. They're going back up into the body, aren't they? And then coming back around by the bladder and back through the ejaculatory duct and out the penis. I don't know if they both work, but there are examples of diphallia where there are two penises. Testes. So we've seen them under the microscope. We know that if we go down, look at the microscope, what are we going to see? What's your visual recollection? What are you going to expect if you look at a slice through the testis? Tubes, 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 right? And all those tubes will have lumens. And what's going to be happening in those lumens? This isn't big enough. It's where you're going to see all those little tails, right? All little sperm going to the center. And then what would be out here in this space? What would be out here between those tubules? The spaces surrounding the seminiferous tubules will have within them Leydig cells or Leydig cells. And those are also called the interstitial cells. These are the testosterone producing cells. So you've got testosterone being produced outside the tubules by these Leydig cells. And that hormone doesn't start being produced until puberty. And of course, that puberty is the onset of secondary sex characteristics. So here, just a picture of the scrotum. Actually, the scrotum is removed. But here's the spermatic cord. Again, what's traveling through there? Vas deferens, testicular artery, testicular nerve, and a group of veins called the papilliform plexus. When we look at the cross-section of the testes, what we're looking at, we're in these tubes, right? Inside these seminiferous tubules. And the sperm are going to be released into the lumen, and they're going to go through a common area called the rete. The rete testis. What would rete mean? Reti, retinaculum, reticulum, retina, rete, network, right? So that means that all the sperm are being produced, and they're all going toward the epididymis, but they're going to go through a common network, right? The rete going toward the epididymis. Now, they're really not swimming yet. Sperm don't really start to swim until they get to the epididymis. That's swimming school. So they're going to learn how to swim in the epididymis. They're going to kind of just float along from the seminiferous tubules through the rete testis and collect in the epididymis. With age and a little bit of lesson, they're going to learn how to swim. They're going to hang out here for a short while, and again, either be apoptosed, broken down, or upon ejaculation, will now make their way through the vas deferens. I've already mentioned the spermatic cord. We know what's in there. We saw this slide already. And so what you're imagining is that this is one humongous, we're looking at the cross-section through a seminiferous tubule. And around the outside edge are these cells, and maybe more of them are coming around, and these cells are the what? Spermatogonia. They are the 46, they are the diploid cells, and they are going to begin making sperm when these cells outside, called the interstitial cells or the Leydig cells, when they start to produce testosterone at puberty, then that testosterone is going to go just a short distance into the tubules and cause these cells to undergo 2 divisions of meiosis, and that's going to give us now 4 genetically different haploid cells with 23 chromosomes each. This whole process is called spermatogenesis from top to bottom, and the sperm will be released into the lumen tail first or flagella first. And again, they're not swimming yet. They're just going to kind of be washed along to the epididymis. There's a unique set of steps that happen between here and here. I went to these in lab. So between the spherical cell and the elongated sperm, that process is referred to as spermiogenesis. This is just a subset of spermatogenesis. And during this time is where we see the mature sperm being formed. So here's a spherical cell. This thing already is a haploid cell. It only has 23 chromosomes in its nucleus, and the nucleus gets pushed up toward the head. The little bag of enzymes that's sitting outside, sort of like the Golgi apparatus in the ER, that's going to become the acrosome at the very tip of the sperm. It will be necessary to penetrate through the outside layers of the egg. The acrosome is going to contain enzymes that can break down the outer layers. The mitochondria are going to get shoved into the midpiece or the neck of the mitochondria, of the sperm. So that's called the midpiece or the neck. And that's the area where the mitochondria are going to be. And then the flagellum is singular, right? Normal sperm only have one flagellum. You'll hear flagella, that's plural. But each sperm only has one flagellum. Now there are out there some sperm, they're mutant. They have 2 flagella, right? And these guys kind of swim in circles and they're not very good for fertilization. So they're kind of mutant little sperm, but they're not that uncommon. The sperm are going to be produced in the seminiferous tubules. They're going to travel off to the epididymis. Again, this is the finishing school. This is about 4 or 5 meters of tubing squeezed into that little epididymis, and it's here that the sperm will become motile. In a male who is very sexually active, the sperm that are being released are actually not mature enough to swim. And so a person who's releasing sperm that have not had adequate time to mature, basically those sperm are not very good for fertilization. So timing is more important than frequency when it comes to getting pregnant. So to have frequent intercourse and the sperm are actually not mature enough is not more beneficial than simply timing it more properly. If they're expelled too soon, they're just not going to be motile. And again, we know that old sperm that are not ejected or ejaculated are going to be broken down through apoptosis. The ductus deferens is going to carry those ejaculated sperm from the epididymis, and they're going to travel through the spermatic cord and go up into the ejaculatory duct, meet with the fluid from the seminiferous, from the seminal vesicle, and enter into the urethra. The urethra in the male is broken up into 3 parts: the prostatic urethra, the membranous urethra, and the penile or spongy urethra. And you've seen this already. And then the sperm will leave through the tip of the urethra. As mentioned in lab, the vagina is an extremely acidic environment, and that helps to prevent bacterial growth in the female. Sperm that are placed directly into the vagina would not be viable. So they must release with alkalinity or with an alkaline solution to help neutralize the vagina. Also, the sperm are going to be surviving for about 72 days, so they need some energy. The sperm are very small. They don't have a yolk sac. They don't have any kind of energy source like the egg does. And so they must have their nutrients provided to them from the seminal fluids. And the seminal fluids are produced by 3 glands, actually 5 if you think about it. There are 2 seminal vesicles, there's 1 prostate, and there are 2 bulbourethral glands. So you've seen these slides before. Let's go through what each of these different glands is producing for the sperm. So the seminal vesicles, 2 of them, again, they're on either side of the bladder, and they're going to meet up with the vas deferens and dump together into the ejaculatory duct. They're producing a whitish, viscous, alkaline fluid that is rich in fructose and prostaglandins. So again, as we went through in lab, the alkalinity was important for the neutralization of the acid. The viscosity is important for the sperm to stick to the vaginal wall and to the cervix. The prostaglandins are important as a smooth muscle relaxer to help open the cervix. And the fructose is an energy source, so the sperm have food for their 3-day journey. The prostate gland, only one of them, walnut-shaped gland, we've seen it, is also producing a milky fluid. It's rich in citric acid, another energy source. Seminal plasmin, a naturally occurring antibiotic, and PSA, which is the molecule which we screen for prostate health. PSA, though, is actually an enzyme that helps to liquefy the semen following ejaculation. So PSA is used to measure in men starting around age 40 or 50, they'll start measuring PSA levels, and if they start to elevate, then it's a sign that the prostate's either enlarging or possibly is become cancerous. And then finally, the bulbourethral glands are going to release pre-ejaculatory fluids. It's going to be a clear mucousy solution which is going to help cleanse the urethra of the acidic urine as well as provide lubricating fluids. Remember that the vaginal vestibular glands are the equivalent to the homologous structure to the bulbourethral glands. So looking at structures from this angle, let me just point and you tell me what we got. So this is a testis, right? And the comma-shaped organ is the epididymis, up and out the vas deferens or the ductus deferens. This gland is the seminal vesicle, and they merge together in the ejaculatory duct, which then dumps into the urethra. The urethra has 3 parts. The part in the prostate is the prostatic. The little part right here in this little area is called the membranous, and then the majority of it is referred to as either the penile or the spongy urethra. It's called the spongy urethra because it's surrounded, think about this going all the way around, this is surrounded all around by corpus spongiosum, and then in this slice you can see both of the corpus cavernosa, the 2 blood-filling regions. Remember in cross-section what we saw in the penis, kind of look like that, right? With the urethra here, the layer around it would be the spongy osum, and the 2 eyeballs would be the corpus cavernosa. This band of tissue right in here, well, yes, that'd be the external sphincter would be in that area, as would be the Cowper glands, and that band of tissue is called the urogenital diaphragm, and the female has it as well. The internal sphincter doesn't show very well here because this is more reproductive than urinary, but the internal sphincter would be at the base of the bladder going into the urethra at the beginning of the prostate. Semen then collectively is the sperm plus the fluids. Each ejaculate normal volumes between 3 and 5 milliliters. This would be in teaspoons what? 5 milliliters is 1 teaspoon, right? So half a teaspoon to a teaspoon, right, of ejaculate would be average. And that normal ejaculate is going to contain between 200 and 500 million sperm. So that's a normal ejaculate. Less than 100 million can be considered infertile. So it takes 100 million sperm to assure the job gets done. 1 egg, 100 million sperm. So under 100 million, there's some issues with reproduction and with fertility, and lower sperm count obviously makes it more and more difficult. If a guy has very low numbers, then it's still possible, though, to combine egg and sperm in a test tube, right? So it's a guy who's producing low sperm can still undergo or still have children, but maybe require a little extra laboratory help. It takes about 2 weeks for the sperm to get all the way through from the beginning to their release. So this is why when you go, well, guys, when we go to the dentist or we go have an x-ray, they'll put a shield over us if they can. If it's an abdominal x-ray, there's not much they can do about it. So the sperm are being irradiated, but honestly, if you don't have any children the next 2 weeks, life is good, because all the sperm are going to be washed out and any potential of x-ray or radiological damage would be minimized. In the female, it's a lot different, isn't it? So cumulative x-rays are an issue in women because the eggs are all sitting there just waiting for their day to develop, and those eggs are being exposed to radiation. So we know that with increased radiation, more x-rays, more mutations can occur in the DNA, which can lead to higher rates of birth defects in women who have birth defects of kids who are born to older women, right? In part because of the cumulative x-rays and just mutations. Again, as I mentioned, the semen of very sexually active male may actually have reduced sperm count because the sperm haven't had a chance to become very motile, and but the glands may keep up with the volume. So the seminal vesicles and the prostate may continue to make normal secretions per ejaculation, but the number of sperm may actually be reduced. And then finally, sometimes fertility issues are as easy as telling the guy to wear boxers, right, rather than tighty-whities, because the tighty-whities are actually keeping the scrotum tight against the body and keeping the body temperature warmer, and the sperm aren't producing at the high enough numbers. And so simply wearing boxers can be the solution for some people who are having difficulty with getting pregnant. Okay, so we're going to skip over. Any questions, first of all, on anything else on male? Anything structurally, sperm production, semen, components of semen, naming the glands involved, or any of the tubing involved?
I just want to make sure on the one slide, it looks like it's page 1448,
Yep.
where it's got step 4, and then underneath that are the full sperm with their tail. So they become that, correct?
So I'm going back to, is this the seminiferous tubule?
Spermatic cord.
Spermatic cord, okay. So say it again for me.
It looks like there's 4 steps, and then it shows the full sperm with the full tail.
Yes.
The head and the tail. So after step 4, that's what they become?
Yes.
Right? Okay.
Yes. This is the spermatogenesis slide?
Spermatic cord, 1448. After testis.
I'm almost there. Hold on. Let me get there.
Yeah. That next one.
Okay, here?
Yep, the next one.
Here.
That one right there.
Okay.
The very bottom.
So as the sperm are released into the lumen, they're mature in their shape and size, but they haven't yet become swimmers.
Okay.
So they're going to be washed along those seminiferous tubules through the rete testis to the epididymis, along that pathway, 2 more weeks from this point until ejaculation, between the transport time and the storage time.
By that picture, I was just trying to figure out where are they going? What is happening?
Okay, so this is that lumen, right? So imagine this is the lumen, the tube, and so when you looked into the seminiferous tubule, what did you see?
The tail.
Right,
Yeah.
right?
Okay.
Okay, you with me now? So this is one huge tube. We've only seen the crest of it. And you've got this big tube that's going in and out of the board, right? And so this is the lumen, L. This is the lumen of that tube. But the lumen goes all the way around, right?
Okay.
Make more sense now?
Yeah.
Good, good. Now lastly, let's go to the last 2 slides here and figure out what happens to these glorious systems when they get older. So we're going to skip over nothing on the exam about viral infections or any methods or surgical methods, nothing like that. And then the last 2 slides, what happens as the reproductive organs get older? Well, the hormone levels become less, as you would expect, and that can lead to atrophy of the organs, atrophy of the breasts. The vaginal wall will decrease in thickness, and this can lead to a lack of moisture and lubrication. We can't even get away from that anymore, can we, in commercials? So painful intercourse. The uterus will shrink a little bit, and a little bit of atrophy will occur. It will actually get down pretty small compared to prepubescent layers. And then finally, if we think about the female, we'll get to the point where there'll be no more gametes being produced at menopause. Now, in the male, however, there really won't be much of a decrease. There is a decrease in the number of sperm produced, but the numbers are still high enough for fathering. So a man in his 70s can easily still father or cause pregnancy in a woman who's still ovulating. So the numbers do drop down, but not below the critical point usually for fertilization. And that brings us really to the end of everything we have to discuss this semester. So what's on our exam? Reproductive structures, urinary system, and reproductive systems, male and female. And that exam will be a full-length exam. We'll meet in here on 4 o'clock on Wednesday, and I will have those graded Wednesday night, and then anyone who's taking it Thursday from hybrid, I would have those graded by Thursday night. If you should get a, let me just say this to everybody, if you should get a survey in the mail, please go ahead and complete that survey. I do value your comments, I do learn from them, and I do make changes in the course as a result. So I don't know why you haven't gotten that yet. By now, usually there's been the survey sent out by the school, but please do take a few moments to fill those out, and I will appreciate that very much.